Okay, this is ventricular fibrillation. Ventricular fibrillation. We see this. Tachycardia and goes to fibrillation. Ventricular fibrillation. This is ventricular fibrillation. Okay, you see this. So you see two ectopic beats. Yes, ventricular of course, and then starting with ventricular tachycardia goes to ventricular fibrillation. We see ventricular fibrillation as a complication of acute myocardial infarction, electric disturbances. So this ventricular fibrillation occurs in 5 to 12% of patients during the first 24 hours after myocardial infarction, usually within the first 6 hours. Late ventricular fibrillation usually indicates continued or recurrent myocardial ischemia, and when compared by hemodynamic deterioration is a very, very poor prognostic sign. So of course we treat this fibrillation with immediate unsynchronized cardioversion. So ventricular tachycardia we treat with cardioversion, synchronized, and this is unsynchronized cardioversion, actually defibrillation. Okay? So now about heart failure. Heart failure is more likely in patients with large infarctions determined. So problems with sound? Yeah? One moment please. Let's check it up. Okay. 1, 2, 3, 4. No, it's okay. It's okay. No, it's okay. So I'm sorry. So we continue. Heart failure is more likely in patients with large infarctions determined by ECG or cardiac markers. Mechanical complications determined by ECG. Mechanical complications, for example, myocardial rupture or aneurysm, papillary muscle dysfunction, hypertension, and diastolic dysfunction. Clinical findings depend on infarct size, elevation of left ventricle filling pressure, and degree of reduction in cardiac output. Dyspnea, inspiratory crackles, and the lung basis, and hypoxemia are common. Treatment depends on severity. For mild cases, a loop diuretic, for example, diuretic, furosemide, 20 to 4 milligram intravenous once or twice daily, it depends on situation actually. To reduce ventricular filling pressure is often sufficient. For severe cases, vasodilators, for example nitroglycerin, nitroprusside, are often used to reduce preload and afterload. These drugs are effective acutely, for example in acute pulmonary edema, and may be continued over 24 to 72 hours are necessary. During treatment, pulmonary artery occlusion pressure may be measured via right heart pulmonary artery catheterization, especially if the response to therapy is not as desired. ACE inhibitors are used as long as systolic blood pressure remains more than 100 millimeter Hg. A short-acting ACE inhibitor given in low doses, for example captopril 125 to 6.25 milligram orally every 4 to 6 hours, increasing doses are tolerated, is best for initial treatment. Once the maximum dose is reached, maximum for captopril 50 milligrams 3 times daily, a longer-acting ACE inhibitor, fosinopril, lisinopril, perindopril, ramipril, is substituted for the long term. If the patient remains in New York Heart Association class 3 or worse, we talk about New York Heart Association classification of heart failure, chronic failure. An aldosterone inhibitor, for example elprenerone, spironolactone, should be added. For severe heart failure, an intraarterial counterpulsation balloon pump or implantable intravascular ventricular assist pump may provide temporary hemodynamic support until the patient stabilizes or the decision is made to provide more advanced support. When revascularization or surgical repair is not feasible, heart transplantation is considered. But this is actually not acute, this is chronic situation. If transplantation, long-term left ventricular heart transplantation is considered, long-term ventricular or biventricular implantable assist devices may be used as a bridge to transplantation. If transplantation is impossible, the left ventricular assist device is increasingly used as a permanent treatment to destination therapy. Yes, destination therapy. Occasionally, use of such device results in recovery and can be removed in 3 to 6 months. Papillary muscle disorders. Okay, functional papillary muscle insufficiency occurs in about 35% of patients during the first few hours of infarction. Papillary muscle ischemic dysfunction causes incomplete coaptation of the mitral valve leaflets, which is transient in most patients. But in some patients, papillary muscle or free wall scarring causes permanent mitral regurgitation. Scarring. Papillary muscle or free wall causes permanent mitral regurgitation. Functional papillary muscle insufficiency is characterized by anepical, late systolic, and typically late systolic purpura murmur, and typically resolves without treatment. So papillary muscle rupture occurs more often after an infero-posterior infarct due to right coronary artery occlusion. In causes acute, severe mitral regurgitation. It causes acute, severe mitral regurgitation. Papillary muscle rupture is characterized by sudden appearance of a loud apical holosystolic murmur and thrill, usually with pulmonary edema. Occasionally, severe regurgitation is silent. An abrupt hemodynamic deterioration raises clinical suspicion of papillary muscle rupture. Echocardiography should always be done to make the diagnosis. Urgent mitral valve repair or replacement is necessary and effective, if you've got the time, of course. About rupture, myocardial rupture. Intraventricular septum or free wall rupture occurs in 1% of patients with acute myocardial infarction. It causes 15% of hospital mortality. Interventricular septum rupture, although rare, is 8 to 10 times more common than papillary muscle rupture. Interventricular septum rupture is characterized by sudden appearance of a loud systolic murmur and thrill medial to the apex along the left sternal border in the third or fourth intercostal space, accompanied by hypotension with or without signs of left ventricular failure. Left ventricular failure. Yes, diagnosis may be confirmed using a balloon-tipped catheter and comparing blood oxygen saturation of PO2 over right atrial, right ventricular and pulmonary artery samples. A significant increase in right ventricle PO2 is diagnostic, as is Doppler echocardiography, which may demonstrate the actual shunt of blood across left ventricle septum. Treatment, of course, is surgery, which should be delayed if possible for up to 6 weeks after myocardial infarction, so that infarctic myocardium can heal maximally. If hemodynamic instability persists, of course, early surgery is indicated despite a high mortality risk. Free wall rupture increases in incidence with age and is more common among women. It's characterized by sudden loss of arterial pressure with momentary persistence of sinus rhythm and often by signs of cardiac tamponade. Surgery is rarely successful. Rupture of free wall is almost always fatal. Free wall is fatal. Aneurysm. Ventricular aneurysm. A localized bulge. A localized bulge in the ventricular wall, usually the left ventricular wall, can occur at the site of a large infarction. Ventricular aneurysm are common, especially with a large transmural infarct, usually anterior. Aneurysms may develop in a few days, weeks, or months. They are unlikely to rupture, but may lead to recurrent ventricular arrhythmias, low cardiac output, and mural thrombosis with systemic embolism. A ventricular aneurysm may be suspected when paradoxical pericardial movements are seen or felt. ECG shows persistent ST segment elevation, and chest X-ray shows a characteristic bulge of the cardiac shadow. Because these findings are not diagnostic of an aneurysm, echocardiography is done to confirm the diagnosis and determine whether a thrombus is present. Surgical excision may be indicated when left ventricle failure or arrhythmia persists. Earlier revascularization and probably the use of angiotensin-converting enzyme inhibitors during acute myocardial infarction modify left ventricle remodeling and have reduced the incidence of aneurysm. Pseudoaneurysm is an incomplete rupture of the free left ventricle wall. It's limited by the pericardium. Pseudoaneurysms may be large, contributing to heart failure, almost always contain a thrombus, and often rupture completely. They are repaired surgically. Hypotension and cardiogenic shock. Hypotension may be due to decreased ventricular filling, loss of contractile force secondary to massive myocardial infarction. Marked hypotension, for example, systolic blood pressure less than 90 millimeter hydrargyrum with tachycardia and symptoms of an end-organ hypoperfusion, reduced urine output, and confusion, diaphoresis, cold extremities, is termed cardiogenic shock. So actually this is a KILIP 4. Pulmonary congestion develops rapidly in cardiogenic shock. Decreased left ventricular filling is most often caused by reduced venous return secondary to hypovolemia, especially in patients receiving intensive loop diuretic therapy, but it may reflect right ventricular infarction. Marked pulmonary congestion suggests loss of left ventricular contractile force, left ventricle failure as the cause. Treatment depends on the cause. In some patients, determining the cause requires use of a pulmonary artery catheter to measure intracardiac pressures. If pulmonary artery occlusion pressure is less than 18 millimeter hydrargyrum, decreased filling, usually due to hypovolemia, is likely. If pressure is more than 18 millimeter hydrargyrum, left ventricle failure is likely. For hypertension due to hypovolemia, cautious fluid replacement with 0.9% saline is usually possible without left heart overload, excessive rise in left atrial pressure. However, sometimes left ventricular high function is so compromised that adequate fluid replacement sharply increases pulmonary artery occlusion pressure to levels associated with pulmonary edema, more than 25 millimeter hydrargyrum. If left atrial pressure is high, hypotension is probably due to left ventricular failure, and if diuretics are ineffective, inotropic therapy or circulatory support may be required. Cardiogenic shock. So KILIP 4, Cardiogenic shock. Approximately 5 to 10% with an acute myocardial infarction have cardiogenic shock. If cardiogenic shock, an alpha agonist or beta agonist may be temporarily of course, effective. Dopamine, a catecholamine with alpha and beta 1 effects, is given intravenous 0.5 to 1 microgram, kilogram, and minute increased until response is satisfactory or the dose is about 10 microgram, kilogram, minute. Higher dose induce vasoconstriction and atrial left ventricular and ventricular arrhythmias. No, left, not left, it's not the moment. Dobutamine, a beta agonist, may be given intravenous at 2.5 to 10 microgram, kilogram, minute or in higher doses. It often causes or exacerbates hypotension. It's most effective when hypotension is secondary to low cardiac output with increased peripheral vascular resistance. Dopamine is more effective than dobutamine when a vasopressor effect is also required. In refractory causes of cardiogenic shock, dobutamine and dopamine may be combined. The combination of dobutamine plus a drug with more adrenergic effect, phenylephrine, yes, and norepinephrine may be effective without causing excessive arrhythmias. And intra-aortic contrapulsation balloon pump may often temporarily support the patient, but recent evidence indicates no short-term or long-term benefit to this approach. Yes, about contrapulsation. Alternatives include the percutaneous or surgical implant left ventricle assist device and occasionally heart transplantation. Definitive treatment for post-infarction cardiogenic shock is revascularization by thrombolysis of the clot, angioplasty, or emergency coronary artery bypass grafting. Revascularization usually greatly improves ventricular function. If coronary anatomy is suitable, percutaneous coronary intervention or coronary artery bypass grafting may be considered for persistent ischemia, refractory ventricular arrhythmia, hemodynamic instability, or shock. About right ventricle. Right ventricle ischemia or infarction. Right ventricle infarction rarely occurs in isolation. It usually accompanies inferior left ventricle infarction. The first sign may be hypotension developing in a previously stable patient. Right-sided ECG leads may show ST segment changes. Volume loading with 1 to 2 liter of 0.9% saline is often effective. Dobutamine or milrinone, which has better dilating effects of the pulmonary circulation, may help. Nitrates and diuretics are not used. They reduce preload and hence cardiac output, causing severe hypotension. Increased right-sided filling pressure should be maintained by intravenous fluid infusion, but excessive volume overload may compromise left ventricle filling and cardiac output. Now about recurrent ischemia. Any chest pain that remains or recurs 12 to 24 hours after myocardial infarction may represent recurrent ischemia. Post-myocardial infarction ischemic pain indicates that more myocardium is at risk or infarction. Usually, recurrent ischemia can be identified by reversible STT changes on the ECG. Blood pressure may be elevated. Recurrent ischemia may be silent. ECG changes without pain is up to 1/3 of patients, so serial ECGs are routinely done every 8 hours for 1 day and then daily, of course. Recurrent ischemia, which is actually classified as unstable angina, class 3, is treated similarly to unstable angina. So I give you a link to unstable angina. Coronary sublingual, intravenous or lingual, intravenous, it depends. So sublingual or intravenous nitroglycerin is usually effective. Coronary angiography and revascularization with percutaneous coronary intervention, stent, or coronary artery bypass grafting should be considered to salvage to salvage ischemic myocardium. Mural thrombosis. Mural thrombosis. Prior to the modern era of reperfusion therapy, mural thrombosis occurred in about 20% of patients with acute myocardial infarction. Systemic embolism occurs in about 10% of patients with left ventricular thrombosis. Risk is highest in the first 10 days but persists at least 3 months. Risk is highest about 60% for patients with large anterior infarctions, especially involving the distal septum and apex, a dilated and diffused hypokinetic left ventricle, or chronic atrial fibrillation. With modern therapy, risk of mural thrombosis is much lower. Anticoagulants are no longer given routinely for primary prevention of mural thrombosis after acute coronary syndrome. Well, no idea, actually. Anticoagulant therapy may be considered for patients with STEMI, so ST segment elevation myocardial infarction, and anterior wall akinesis or dyskinesis, but the patient's risk of bleeding must also be evaluated in light or dual antiplatelet therapy and resultant triple therapy should anticoagulation be chosen. Anticoagulants are recommended for patients with myocardial infarction with concomitant atrial fibrillation and high thrombogenic risk, mechanical heart valves, venous thromboembolism, hypercoagulable disorders. It also is reasonable to give anticoagulants to patients with STEMI and asymptomatic confirmed left ventricle mural thrombi. About pericarditis. Pericarditis results from extension of myocardial necrosis through the wall to the epicardium. It develops in about 1/3 of patients with acute transmural myocardial infarction, although the rate appears to be much less in patients who have early reperfusion done. A friction rip usually begins 24 to 96 hours after myocardial infarction onset. Earlier onset of the friction rip is unusual, although hemorrhagic pericarditis occasionally complicates the early phase of myocardial infarction. Acute tamponade is rare. Pericarditis is diagnosed by ECG, which shows diffuse ST segment elevation, and sometimes PR interval depression. Echocardiography is frequently done, but the results are usually normal. Occasionally small pericardial effusions and even unsuspected tamponade are detected. Aspirin or another non-steroidal anti-inflammatory drugs usually relieve symptoms. Colchicine 0.5 to 1 mg orally once a day alone and especially added to conventional treatment speeds recovery and helps prevent recurrences. High doses or prolonged use of non-steroid drugs or corticosteroids may impair or infarct healing and should be avoided. Corticosteroids may also increase the likelihood of recurrence. Anticoagulation is not contraindicated in early peri-infarction pericarditis, but it's contraindicated in later post-myocardial infarction syndrome. Dressler syndrome. Yes, Dressler. So, about Dressler. Let's talk about Dressler. Post-myocardial infarction syndrome develops in a few patients several days to weeks or even months after acute myocardial infarction. Incidence also appears to have decreased in the recent years. Why? Actually, a lot of speculation. It's characterized by fever, pericarditis with a friction wrap, pericardial effusion, pleurisy. Yes, leave it. pleuritis, pleurisy, pleural effusions, pulmonary infiltrates, and joint pain. The syndrome is caused by an autoimmune reaction to material from necrotic myocytes. It may recur. Differentiating post-myocardial infarction syndrome from extension of recurrence of infarction may be difficult. However, in post-myocardial infarction syndrome, cardiac markers do not decrease significantly, and ECG changes are non-specific. Non-steroid drugs, anti-inflammatory drugs, are usually effective, but the syndrome can recur several times. Colchicine is effective for treatment to prevent recurrences. In severe causes, a short intensive course of another non-steroid drugs or corticosteroid may be necessary. High doses of non-steroid drugs or corticosteroid are not used for more than a few days because they may interfere with earlier ventricular healing after an acute myocardial infarction. So that's all. Concerning myocardial infarction. My dear friends, that's all. Actually, we have to understand that this is the same continuum. So, acute coronary syndrome, myocardial infarction, stable angina, the same situation. Pathology, etiology, pathophysiology, treatment, drug treatment, revascularization techniques, etc. So once again, thanks for your attention. Don't forget to make your donations because without your donations we can't exist. Absolutely. Don't forget to make your donations, and before this, subscribe before your donations. Subscribe and follow our channel, and see you in another lectures. They will be very, very interesting. Bye.